Let's be upfront here. Welcome back to the trash edition of News Gang. From truckloads of garbage headed to the Kenya Power and Lighting Company offices to a healthcare system that is literally at a standstill. It's been a nearly nothing is working week for systems in Kenya. This notwithstanding, the last-minute arrival of the police service and the Ministry of Interior, which had apparently or seemingly been away on leave when the Anarchy caravan hit the streets of Nairobi. In politics, roses have replaced the rainbow, and the broad-based government is conducting public participation. How broad will it get? On Sam's sense, it's another load full of trash. Jamila's memo is directed to any adults that can do anything about SHA. Bonyo picks a bone tonight with the handling of the Todonyang attacks. Kaikai's kicker wonders what next after the KICC RSF meeting. And on my take, the Q1 audit report on political dishonesty. The gang is here.
Unfortunately, the systems are still not working. The hospital is not receiving these reimbursements in time. And this we've been for the last 4 years. We try, we cry, we appeal, we plead. Sometimes they say that we are complaining too much or that we exaggerate.
Ladies and gentlemen, welcome to the gang tonight, and to you, our viewers. The hashtag is NewsGang at Citizen TV Kenya. So, what a week. Let's start at the natural place to be. I mean, I think we were not well this week. Neither was the air, quite frankly. But let's start with this system. We've seen Anthony Muheria there, Bishop in the Catholic Church, because they, many faith-based hospitals that have been bearing the brunt. We will come to possibly 5 days tomorrow of the private hospitals now refusing to take any patient under the SHA care system and basically demanding cash for treatment. Jamila, take us through what this week has been so far.
Yeah, this week has not been good for the health sector, Yvonne. And let me take you back to the week before when RUFA, that is the Rural Urban Private Hospital Association, issued a one-week notice saying that we are unable to continue receiving patients under SHA because of non-payment. Remember, many hospitals still have Madeni and NHIF, about 30 billion shillings, which have not been paid. And despite promises, all indications are that maybe that money is not going to come through. So they have to start thinking about what next. So RUFA said that by next week, which was Monday, they're going to stop offering services unless you come and pay cash. I think over the weekend, was it on Sunday, they broke down a bit of what they'll accept and what they will not accept. Of course, they say emergency and primary care, they'll give it. But then they even gave that if you're admitted from a certain date, you'll not get service. If you're admitted after this particular date, you'll not get service. So it's a huge mess. And today we saw a story about how now this is starting to affect people. The public hospitals are overwhelmed. No one is going to the private hospitals, or even if they are very few because you have to start paying cash. And Yvonne, this is a huge problem. And it's just not one of the first challenge that SHA has faced. Of course, with the issues with the 30 billion shillings that the hospitals wanataka walipwe. But today we had a story about stakeholders who had been involved in this whole thing from the beginning, talking about how when the initial idea came up, it was a noble idea. Yeah, affordable healthcare for all, because NHIF had issues with corruption, with the system. And those experts, when they sat, they said they need about 700 billion shillings to be able to roll out this thing successfully. But then now they kept getting the response that there's no money, there's no money. And because of that, you have these four funds, but then the financing gaps are evident, especially in two of them, the primary healthcare and the emergency and chronic and critical illnesses funds. Yeah. At the rollout, the government allocated 6.1 billion shillings against the required 50 billion for the primary healthcare fund, and 4.1 billion against the needed 75 billion for the emergency chronic illnesses. Now, these funds have no money. The government is supposed to give the money for these funds, but it has not. SHIF is the one that's working kidogo because of why? The contributions that we're giving. That's where the money is. But Yvonne, this is still not working because now you have faith-based hospitals. I think they were the last resort for a lot of people. saying that we're also having issues, there is no money. So where does this leave people? Remember, there have been complaints from these experts and these stakeholders in the health sector saying this thing was rolled out too fast. There were things that were supposed to have been done that are not done. Even things like means testing. We are supposed to determine, okay, this is how much money this family is supposed to contribute to the fund. Remember, Yvonne, as it stands, about only 3 million people are contributing to the fund because mnakatwa at source.
Right. So
there are these people in the informal sector also supposed to changia fund, but they are not because, one, means testing haijafanyika, so hujui utawachaji watu pesa ngapi. So pesa haingii kama inavyotarajiwa. So all this coupled with what's happening with Rufa and the money, Mkenya anateseka.
Yeah, and you know, the funding is the biggest thing. You know, you remember what was being said at the start or the rollout of SHA was that there would be no more harambes, and that, you know, the idea would be that every Kenyan, or rather the argument of moving from NHIF to SHA was that NHIF basically dealt with the salaried and enabled them to get access to healthcare. And so moving towards SHA and creating all those 3 funds, like you've mentioned, the primary care, the emergency care, and of course SHIF, which is contributory, the idea was to ensure that every Kenyan has access to quality and affordable healthcare. Was the government too ambitious? Because even the fund that you're talking about, initially the primary care fund was meant to be 68 billion. They revised it down to 50 billion and of course allocated it less than a tenth of that. The emergency fund was supposed to be 107 billion. They revised that down to 75 billion, and then we know what they allocated it, again, which is less than a tenth of what that is. Had the government properly understood where the money for this was going to come from, considering everything that was going on in the country at the time, our debt crisis, our revenue collection mechanisms, and all of those that have fallen short, even with SHIF, in so much as it is working, 80%, how it was designed was that 80% of the contributions would come from the informal sector. That means testing has not happened or is faulty or is not working. Even if it did work, what is the method of enforcement to ensure that those who are not salaried, in other words, you do not have access to their earnings to be able to deduct at source, where is that? So that it was supposed to be 80% from the informal sector and 20% from the formal sector. So right now what is happening is that the 20% from the formal sector are the ones bearing the burden and carrying, what was it, the one with numbers, was it 156 billion shillings that they were supposed to have collected, I think, you know, under SHIF?
They should collect up to 148 billion.
148 billion. And so if we're not careful, even SHIF will collapse, because the 20% cannot carry the 80%. And so essentially what we're saying, by the way, when you know, we say SHIF is not working, it's actually SHA, which is the primary care and the emergency, for which people are supposed to be able to walk into a hospital and get the care that they need. And just so we understand, the primary care fund and emergency care fund was supposed to offer the basic services at level 2 and level 3 hospitals. And some of the things that they were to get access to is consultation, diagnosis, preventive care, restorative treatment as necessary. And by the way, it's really good for the chronic ailments, diabetes, if you've got kidney disease, dialysis. And that is why you see most of the complaints are from persons who are living with chronic conditions. This is the one thing that the government had promised and said there would be no more harambes. And yet they didn't put the money where their mouths are. That is one of the interesting things about this. But then again, Jay, this is also about the rollout, because it would seem that SHA has had problems from day one.
Thank you. Yvonne, clearly this is a flaw in the design thinking process, because every imaginable end user has said this product is bad. The only possible thing that needs to be done is to relook at it and see how best can it work. And it speaks volumes to what this administration has done since it came to office in September of 2022. It simply put the cart before the horse. We did numerous stories around this big animal and how the end users had initially raised concerns around it. And their suggestion was, can we take at least 3 years before we roll it out? But they were told it has to happen. And the feedback that they're getting right now was anticipated. And the worst part of it is that every senior government official in the last 2 weeks have admitted. So who else are they waiting for to tell them that this is bad? Look at Professor Kindiki, the Deputy President. He has admitted. Look at Deborah Barasa, the CS Health. She has admitted. If you speak to senior directors of the Ministry of Health, they'll tell you the same thing, that they're channeling out something that they too do not want to understand and to believe in. Because it seems it's a project that came from somewhere and was handed over to the Ministry of Health, and they were told, guys, this is your baby, please take care of it. They don't understand it, and that is why you see them struggling to even do basic explanations on what exactly is this supposed to do. Yeah. You remember last week they said they were going to raise a supplementary budget. Yeah. I mean, how do you raise a supplementary budget in less than 4 months of a system that you told and assured Kenyans would work efficiently? It tells you there's a problem.
Yeah, I'd like us, before you come in, to listen to Brian Leshenga. He's the CEO of RUPA. He's been speaking on this issue, just talking about how unsustainable this is.
Model is unsustainable. We were involved in the financing discussions. I remember we started from 700 billion, 465 billion, went down all the way to 275 billion. If you imagine, you pay out everything you collect, and the bills are coming in every single day. For me, my concern is that this runway is going to run out. It's going to run out really quick. And the reason why it's running out is that the model is unsustainable from the word go.
This is what you were talking about, Jay.
Exactly.
Yes. Yeah.
End user feedback is very, very important in a design thinking process. So
and Brian did say they were involved in this from the start and had given this feedback, everything you're saying, you know, from the beginning. Yeah. I just want to get the views from Sam in a minute, and we'll come back to you.
Right. And I think what is crucial here is also the inconsistency in terms of what the government is communicating, all the way from the numbers to the reality of even the claims that are being paid to the hospitals. You recall that the reason why the RU-PHA affiliated hospitals are on strike, or they are not admitting patients with SHA cards, or SHA as the mode of payment, is because they're saying you've not paid our money. They have not been paid the 30 billion shillings that is owed to them from the NHIF. And I saw the other day the Cabinet Secretary promising the Senate that they are speaking to the National Treasury, that they have been in conversations to see that those resources are settled. But also in different quarters, you also hear people saying that those bills could have actually been inflated. So you're wondering, what exactly is the reality on the ground? There's a clip that we'll be listening to from the Chief Executive Officer of the Social Health Authority, that is Robert Ingasira, where he's talking about the numbers of the facilities that have been contracted. Do you have that?
The facilities membership under RUFA is just about 300. So we still have a whole 8,000 facilities out here which are offering services. If there is any member who is being turned away because of one reason or the other, then like I said, we will invoke the whatever clauses that are in our contracts with them.
Yeah, in the earlier part that you didn't hear, he's talking about the facilities that have been contracted. He's putting the figure at 8,600 facilities. Now, what is interesting is that the past few days we've been hearing about a lot of numbers. There was a campaign going on online about, is it Ukweli wa SHA? You may have seen that, where they are saying that, yes, Ukweli wa Mambo, about Taifa Care payments. They're saying that SHA has contracted over 15,000 facilities in the public and private sectors, that the signed contracts stipulate that all claims are paid within 90 days. Also says that notwithstanding this provision, SHA has been paying claims every end month. All SHA claims up to 31st of January have been fully paid. That's according to Taifa Care. But the same government or the same institution had some communication, and this was, let me just see when this was, 6th of January 2025. And they gave a breakdown of, of the facilities that have been contracted. Guess what the total was? 3,993. In just over...
From 8,000 plus.
So 6th of January, there were 3,993.
And before there were 15,000.
And now...
What happened to the 12?
No, just hold on. So January 6, it was 3,993 facilities have been contracted. In a communication that is seen online about Ukweli wa Mambo, they are talking about 15,000 public and private hospitals.
Oh, wow.
The CEO of SHA spoke this week.
8,600.
8,600 facilities. So just how many facilities has the Social Health Authority contracted to offer services, and are patients across the country aware which institutions are contracted? Because at this moment, you're talking about...
Because even the government doesn't seem to know either.
We're talking about the crisis in hospitals.
Yeah.
Remember last week, 11th of February, we got numbers from the Minister of Health, the Director General, and the Cabinet Secretary, Deborah Baraza. They were speaking about the numbers, saying that we have, yes, 19.3 million. Now I think it's more than that. It's close to 20 million registered persons. But out of those, it's only about 3.6 million that had been taken through the means testing instrument and were contributing. They even give figures about the average contribution as of now. It's about 584 shillings out of the 3.6 million people that have been taken through the means testing instrument. If you do the math, you'll see the sort of resources you're talking about. So how is it that patients are stranded across the country because they cannot access shift services, yet they have not been making their contributions? Because if you do not make the contribution, you don't get the service.
Yeah.
So why not just clarify what exactly is happening so that people don't say that SHA is not working, yet they're not contributors? There's clarity that is lacking there.
Before Yvonne, sorry, just on the same, before Linus comes in on the facilities, when the acting CEO says that whatever we have in our stable is enough, if you look at those hospitals that he was talking about, a majority of those are level 2, level 3 hospitals that offer the primary care. Unaumwa na kichwa, uko na fever, unaenda pale. But then now, a majority of those that have withdrawn their services are level 4, level 5, where you go for the specialized treatment. But the problem we even have in the level 2 and 3 is some of them are not equipped. So someone goes there and they're unable to get services, so they'll have to go to the level 4, level 5, where they'll have to pay for that service. And that's just one. And two, the hospitals under RUFA were called into a meeting, and we're listening to Dr. Lishenga talking about it, and they were given a form and told to fill how much money they think that they owe NHIF, what their claims are. Apparently, the government has no access to the claims because they've been shut out of the system. This is because the system admin, who had all the logins, his contract was terminated. Kabla time yake haijafika. So the person went away with their login, and then they want to be paid for the remainder of this contract so that afungue login. And as we've said, SHA was rolled out when it was not ready. So and then you have this cluster of people who are the most vulnerable, the widows, the old, the aged, who actually depend on SHA completely for everything, unable to afford it at all. What happens to those people? And then there are those who have been paying contribution. Yvonne, you and I have experienced this in the past couple of months, where you actually pay the amount of money every month, but then when you're admitted in hospital, what SHA pays for you is less than a quarter of what your total bill is. It happened to you, it happened to me, more than once. And then now we have this thing called the overseas package, Yvonne, which is only available for civil servants, but there's a limit. You can spend up to 500,000 shillings only. You who pays monthly contributions are not entitled for overseas package under SHA.
You know, these numbers just aren't making sense. Even when you talk about the claims, which is what the hospitals are complaining about, and who can see what. According to RUPA, apparently 83% of facilities have trouble with verifying patient eligibility. And so on that basis alone, they are, not able to verify which patients can come in for claims. 74% of the hospitals said they can't reach SHA for any queries, not even by phone, when they have a challenge. SHA workers themselves, we've heard reports, don't have access to this portal. Remember, this was something that was costed at 104 billion shillings that was said to have been an upgrade. The systems at the different levels don't seem to speak to each other, because the idea was if you go from a level 2 to a 3 to a 4 and 5 facility, that the one at level 5 is able to see everything that has happened, which doctor or which clinician attended to you, what were the tests. These systems are not speaking to each other. In fact, the idea of even having a system such as this, with the challenges that we have in this country, access to electricity, access to the internet, access to the equipment, Guys, on all fronts, you know, SHA isn't looking good. Even when you take a look at what the clinicians, the nurses, the doctors have been talking about, this word that we've been hearing, like empanelment. So initially, the SHA portal only recognizes those practitioners who are registered under the KMPDC. That does not include clinical officers. That does not include nurses. They've been asking the nurses to then pay fees to KMPDC and move away from the nursing council and that sort of thing. But here is where the issue is with just getting everybody in terms of, looks like it's all in the details, whether it's getting the system recognized, whether it is the funding. So it looked big on paper at this level, that yes, this is a good, big thing, but when it comes to the finer details, Linus, that's where it's lost in translation.
Yes, Yvonne, and I heard you say that systems are not speaking to each other. And of course, the other big question is, are the people in charge of the systems speaking to each other? And I want us to listen to the Cabinet Secretary for Health, Deborah Baraza.
Insurance citing millions in unpaid dues, a crisis that now threatens access to healthcare for thousands.
System challenges. This is not new. Systems do have challenges, and even when you look at the best systems in the world, you know, NHS, waiting time is always a challenge. System interruption can occur.
You see, she gives the example there of NHS, which is the National Health Service.
In the UK.
A system that is the pride, one of the pride of the UK. It has challenges, yes, but don't put it in the same line as SHA. You cannot do that, and not at this stage. One of the things that have been clearly missing is voices, and I feel it for the CS Baraza there, because so far we are not feeling the ownership of this process. It's not coming as loudly as it used to come up as a campaign promise. It's not that promise. It's not that promising. And I just want us to listen to patients, because this is where really it is hurting. Let's listen to the patients, Douglas Ayori, and there's also Moses Nyambane, who have gone to hospital and experienced difficulties.
They should have an alternative way ya kufanya hii insurance ifanye kazi. Kama ifanye kazi warudishe ile NHIF.
Tumelazimika kulipa kila kitu. For anything that has been done here, we are paid. Hata mnaanza kuona marisiti mkononi.
Yes, indeed, and those are the patients. Here is where we have the problem, and you spoke, Jamila, I think, illustrated earlier the coverage of SHA. We have a problem with SHA because decision makers do not rely on SHA for their health coverage. I think that's where the problem is really coming from. Those who are suffering because of the system not working are only the regular folk. The rest are on very private medical care that works. And I saw one of the members of parliament, I think that is, was it Sabina Chege, who's saying that she wants to bring up a bill that will force everyone to be covered by SHA. Because only then can we have a coherent conversation about SHA, because we have no coherent conversation right now. You know, the last time it felt like this is when CBC was introduced. You can tell it's not about those decision makers. It is an us and them kind of scenario, which is why SHA is not getting the attention that it deserves. You still see our political leaders going about their business very much and aggressively on broad-based arrangements. How about a broad-based approach to SHA, and urgently?
Yeah, and like you say, it's an us versus them, which explains why, you know, a section of members of National Assembly at some point admitted that they weren't really sure of what they passed when they were passing the laws. And this went through a rigorous process. It was public participation. Were they even not part of that? And this is where the problem begins with. If they pass laws that they didn't know, But then again, why would they? Because this doesn't apply to them to begin with, right, Sam?
And I think at this point in time, the Social Health Authority, Minister of Health, and everyone who is involved, who has a stake in this, at least from the policy implementation side of view, they should seize this campaign of register so that you can get services. Because I mean, what is that? I heard, even at the coastal tour of the president, that there is still the call that Kenyans are encouraged to continue registering because once you register, you can access healthcare services. Well, yeah, because you can access primary healthcare services. But let's remember that only 4 billion shillings was allocated to this current financial year. I hear there is a plan to have a supplementary budget so that we have more resources allocated to that. But as we speak, the budget that the government of the Republic of Kenya that is implementing, it is up to 4 billion shillings. And the number says that 1 million Kenyans have already gone for what you call the primary healthcare services. Remember, you assigned 900 shillings
per year.
Per person? Yes,
per person.
Yes, it is per person.
So if, assuming the 1 million would have opened the space for 900 shillings, what is that? It's 900 million shillings. Has that been settled with these hospitals? There's no communication on that, whether it has been sent to these facilities. So for me, I think the most important thing, if the ministry is already saying that, yes, we have so many registered, but very few registering, then the focus has to be different. You have to focus on the quality of service, but also how do you ensure that every member that is registered is contributing? When you look at the numbers, I mean, it's a headache of numbers, because you start now getting to understand that actually the numbers were given, that 9 million were transferred from NHIF to Social Health Authority, they're not true. I'm trying not to say they're lies, because the figures from the same institutions are showing you that it's only about 4 million people that were transitioned from NHIF to Social Health Authority. So why tell stories that are not true while the facts are there, and you can actually use facts and truth to have a better approach to implementing a program such as this?
And I think the other thing that needs to stop happening is the vilification of hospitals, particularly those in the private sector. And when we speak about, you know, the Rural Urban Private Healthcare Association, the members of that, by the way, those are the ones that deliver 45% of primary health care services in the country. 30% of the level 4 healthcare facilities, you know, are under RUPA. And the idea that one would expect them to provide this service for free or with no money, when we know how hospitals run. Staff need to be paid. Equipment, it is the most equipment-intensive industry that I personally know. Everything, you spend money on that. A syringe, you know, a piece of cotton wool, gauze, you know, stitches, needles, sutures, you name it, it needs to be costed. How are they supposed to run when they are not receiving the monies that are owed to them? I mean, they're not doing, you know, this work for free. And which is why they are now saying, okay, you know what, now we're not going to go on the credit system. We will have people come in and pay cash. And if indeed the government expects these hospitals to provide quality healthcare, then that comes at a cost, which the government itself said, we are going to pay for primary care. We are going to pay for emergency care. If the government was not prepared, and surely there are people in this government that do numbers and understand the difference between 3,000 and 15,000. It's a huge difference. Surely this math would have been done and calculated in advance for them to understand this. I mean, when these guys are saying that they haven't received monies, you know, since December, since January, you would then understand why they would say, you know what, we're not taking this on a credit arrangement. You come in with cash. It costs money, even just keeping the lights on at a hospital facility that is running 24 hours a day, making sure that, you know, you've got enough spirit and sanitizer and all of that to make sure that you have, you know, a space that is sanitized and enables you to get the quality of care that you require. I mean, there has to be an understanding on that. And when, you know, these hospitals give their data, government doesn't come in to refute the data or give their own numbers, well, save for registration, but in terms of how much money has been given. So if the private hospitals are lying or not telling the truth, and what is the government side of things in terms of saying, look, we've given them the monies up until February, you know, last week. But we don't hear that. And we can't expect them to do it for free. Everything comes at a cost.
Absolutely. And Yvonne, the tragic bit of this is that the economy is shortly going to start feeling the effect of these non-payments.
Yeah.
Because hospitals are saying we are unable to keep staff.
Yeah.
And they're not able to keep staff, it means they let people go. And already the economy is nearing its knees. So the same government that is talking big about propping up the economy and doing everything so that Kenyan economy can work is the one frustrating it.
Yeah.
At this point, I think the government needs to call itself to a meeting and just ask, was this the best way out, or is there anything else that we can do? All these experts can all be lying.
Yeah.
These are the people who run these hospitals day to day.
Yeah.
So the data they're providing you, the information they're giving you is the most accurate information you can want to use to make this system better. But they're being vilified.
Yeah.
It's a problem.
And you have UHC workers striking all across the country because, hey, they want permanent and pensionable employment. Remember, these are the ones who are employed in 2020 under the UHC COVID-19 contracts. And they're saying they've been lied to. They had been promised they're going to be given permanent jobs, and they're striking all across. And then on top of that, the clinical workers, clinical officers are also on strike. And remember, these are the people who ukienda pale hospitalini for the primary health care, the clinical officers are the ones who wanapata hapo kukupa huduma. Those guys are also on strike. Yeah. And they've accused the government of actually ignoring them and not listening to their plight. So you have SHA that's not working. You have private hospitals that are saying you're not going to receive patients if you're not paying cash. You have the UHC workers who are on strike. You have the clinical officers also on strike, and then you expect people to be okay in this country.
Yeah.
It's a mess. It's a huge mess.
Yeah.
Yeah.
There's another data set just before you go. There's another data set here that is interesting, and the Social Health Authority talking about total claims. The date doesn't indicate here, but the total claims volume was 584,000, and submitted claims value was 11.2 billion shillings. The verified claims value was 11.2 billion shillings, meaning that the submitted claims have also been verified to be true and accurate, that they need to be processed. But then the information, and this is excluding the primary health care. So this is what would come to SHIF, SHIF payments. Okay. And maybe the ECCF, that is, what is ECCF? Emergency Chronic and Critical Care Fund. Yeah. But then it doesn't indicate how much money has been paid out. So you talk about the submitted claims, the verified claims, but the settled claims, it doesn't say. Yeah. But if you're talking about the figure of 11.2 billion shillings, this ideally should come from either the SHIF contributions or that emergency fund, which is allocated 2 billion shillings. So let's assume it's 2 billion shillings that is coming from 11.2, which is not possible. So you have a balance of 9.2 billion. This 9.2 billion shillings should be coming from SHIF contributions. Yes. How much has the government been collecting from SHIF since October 1st up to now? Do they say? No, they don't. But they tell you that 3.6 million people have been taken through means testing, and the average contribution is about 584 shillings. 584 shillings times 3.2 should give you about 1.6 thereabout billion shillings. That is not enough to settle 9 billion shillings. Why not communicate this and say we're short of cash because the contributors, the 19 point so million people are not necessarily financing their SHIF contributions, so that after that you give that information, the stakeholders are clever people. They'll tell you what you can do. If they cannot tell you what you can do, you can figure it out because in any case, you're the owners of the program.
Let's take a break. We come back, we talk about another system failure, total system failure that happened in the capital, no less. You know, I'm not allowed to use expletives, so let's take a break because we're about to talk trash when we...